This is Miss Woodard, and this is your Chapter 8 Pathophysiology lecture on altered fluid and electrolyte balance. Here are your objectives. So what are electrolytes? They're electrically charged particles or ions dissolved in body fluids. And you have negative ones, which are called anions, and you have positive ones, which are called cations. The concentrations of each vary depending on which compartment you're in, meaning your intracellular or extracellular space. And the goal is to achieve homeostasis, or when it comes to these electrolytes, it's electroneutrality. So you're going to have a different concentration of cations and anions on opposite sides of the cell membrane. You can see the difference in the distribution of ions across the membrane here. You need to commit these to memory. You can see that these are the ones that we usually need to know. Because these are the ones that we can test, the extracellular concentrations, which to us are the intravascular or serum values. So how do these anions and cations go back and forth across the membrane to achieve homeostasis? Well, remember from chapter 2, the methods of transportation depends on the size of the particle, and some are passively transported via diffusion or facilitated diffusion. But when you have those cations or anions that have an affinity for one space and they need to go in the opposite direction, like the sodium potassium pump, then you require energy. So just refamiliarize yourself with those means of transportation. Here's the nomenclature for alterations in electrolytes. So when we talk about sodium imbalances, you're either hypo or hypernatremic. With potassium, it's hypo or hyperkalemic. With chloride, it's hypo or hyperchloremic. Calcium is hypo or hypercalcemia. Magnesium is hypo or hypermagnesemia. And phosphate is hypo or hyperphosphatemia. Your book doesn't discuss these in too much detail, but these are very important for you to know. So I'll discuss them in further detail here because this is what you're going to be seeing as nurses. There's a chart in your book on page 201 that gives you an overview of these, and that's pretty much the meat of what you need to know. What I'll discuss is the mechanism behind the manifestations, because like I always say, if you understand what's going on at a cellular level, you can rationalize the manifestations and you don't really have to memorize too much of that chart. So just to review sodium, it is important for the maintenance of the extracellular fluid volume through its effects on osmotic pressure, because it makes up about 90% of the solute in extracellular fluid. Sodium is also essential in the conduction of nerve impulses and in muscle contractions. This diagram here is a review of sodium's role in nerve conduction. Sodium is the main extracellular electrolyte, and potassium is the main intracellular electrolyte. But the thing is that each electrolyte has an affinity for the opposite space. Homeostasis between the two electrolytes is maintained at great energy expenditure by the sodium potassium pump. And it's important to remember that these two electrolytes all work inversely to each other. So sodium also exists in the body primarily in the form of the salts sodium chloride and sodium bicarbonate. You can get sodium, of course, by ingesting it in food and beverages, and you can lose sodium through perspiration, urine, and feces. Sodium levels in the body are primarily controlled by the kidneys, and this is through the actions of aldosterone. Hyponatremia refers to a serum sodium concentration below 135 milliequivalents per liter. Um, Remember that we have you memorize these electrolyte levels and other lab levels in school so that you can have a familiarity with the range of normal in the for serum labs. However, when you get, and you may have already seen this in some of your in your clinical rotations, when you look at the labs, each facility, depending on how the labs process the samples and also, lab equipment, the values may vary slightly, just slightly, like only by a few milliequivalents, not, off by 10 milliequivalents. So that's just a little side note. So the causes of hyponatremia can include excessive sweating, vomiting, or diarrhea, a diuretic drug, low salt diets, hormonal imbalances like that affect the amount of aldosterone, like adrenal insufficiency, or either excess antidiuretic hormone secretion. Extreme diuresis, sweating and peeing a lot, those can both cause hyponatremia, as well as excessive water intake. Remember that water flows where salt goes. So now there's more sodium inside the cell than on the outside of the cell. So what ends up happening is the osmotic pressure on the inside of the cell is greater. So that means water goes into cells, causing them to swell. Okay? Now you have decreased fluid outside of the cell or in your vasculature. So this causes hypovolemia, which thereby decreases blood pressure. The swelling of the cells, depending on which body system we're talking about, can cause the remainder of the clinical manifestations. So in brain cells, it causes cerebral edema. So this means a person can get confused, have headache, weakness, and seizures. Low sodium levels also impair nerve conduction. And those associated manifestations are the fatigue, muscle cramps, abdominal discomfort or cramps, nausea, and vomiting. This just shows the shifts of fluid into the cell. So you have that low sodium concentration in the blood, which means there's a low osmotic pressure in the extracellular fluid. So the fluid gets sucked right into the cell where that osmotic pressure is higher. So the water has a higher affinity for inside the cell. And then as a result, those cells swell. If it gets too severe, the cells can also rupture. Hypernatremia is excessive amounts of sodium in the extracellular fluid or intravascular space. This can result from ingestion of large amounts of sodium without proportionate water intake, or loss of water from the body faster than the loss of sodium. Some specific causes can be insufficient antidiuretic hormone, like with diabetes insipidus. That just results in large volumes of diluted urine. So the person is having all of this fluid loss, but not the sodium loss. Also, the loss of the thirst mechanism can cause this. So that would be an example of inadequate intake in fluid. Watery diarrhea would cause loss of fluid, and prolonged periods of rapid respiration can also cause hypernatremia. The major effect of hypernatremia is that fluid shift out of the cells uh, due to the increase in osmotic pressure in the interstitial space or the extracellular fluid. This effect is manifested by weakness, agitation, and the hallmark is edema. The person will have dry, rough mucous membranes, increased thirst, and an increased blood pressure. Just think about this as now we have an increased amount of pressure in the vasculature, or more tension in the vasculature due to the increased fluid. Think about what happens when you blow up a balloon. The more water or air you put in it, the tighter the rubber is. So that's the same thing. That's the same principle when you think about how the shift of fluid into the cells due to the sodium is, into the vasculature causes an increase in blood pressure. Just a review of potassium. Potassium is the major intracellular cation, and because of that, the serum levels are very low when you compare them with the intracellular concentrations. We get potassium by ingesting it in food, and it's excreted primarily in the urine under the influence of the hormone aldosterone. Foods high in potassium include bananas, citrus fruits, tomatoes, lentils, and things of that nature. Insulin also promotes movement of potassium into cells, and this is important to know when you're treating certain metabolic disorders. And we'll talk about the relationship of potassium, especially in metabolic acidosis, during our next lecture. Because potassium influences, the levels influence acid-base balance in the body, and conversely, acid-base balance affects potassium levels. Potassium is important in nerve conduction and muscle contractions of all type, because it determines the membrane potential of a cell. And most importantly, abnormal potassium levels can cause serious effects on the contractions of cardiac muscles, and it can be life-threatening. You can see the relationship between potassium and hydrogen ions here. Acidosis tends to shift potassium ions out of the cell and into the extracellular fluids, and alkalosis tends to move more potassium into the cells. With acidosis, many hydrogen ions diffuse from the blood into the interstitial fluid because of the high hydrogen ion concentration in the blood. When these hydrogen ions move into the cell, they displace the potassium, and that's just to maintain the electrochemical neutrality. But then the excess potassium ions in the interstitial fluid diffuse into the blood, and this can lead to hyperkalemia. And the reverse process occurs in alkalosis. So acidosis promotes hydrogen ion to be excreted by the kidney and the retention of potassium in the body. Just remember this when you discuss DKA in MedSurg. Here are the signs and symptoms of potassium alterations. You can see that the manifestations are related to nerve conduction, metabolism, and cardiac activity. So hypokalemia is a serum potassium of less than 3.5 milliequivalents per liter. And this may result from excessive losses from the body due to like diarrhea or diuresis associated with certain kinds of diuretic drugs. Patients with heart disease who are being treated with certain diuretic drugs like furosemide have to increase their potassium intake in their food, or either take a potassium supplement because hypokalemia may increase the toxicity of heart medicines such as digitalis. The other thing that could cause hypokalemia is excessive aldosterone or glucocorticoids in the body. So that's like in Cushing syndrome, where glucocorticoids have some have activity that promote the retention of sodium and favor excreting potassium. Also, decrease dietary intake, and this occurs frequently with eating disorders, starvation, or alcoholism. And then also the treatment of diabetic ketoacidosis with insulin can cause hypokalemia. The effects of hypokalemia include cardiac dysrhythmias, and they're generally serious ones. On an EKG, you can see that, well, we'll talk about it on the next slide. Let's talk about the other stuff. So there's an interference with neuromuscular functions because the muscles are less responsive to stimuli. Remember, potassium determines the membrane potential. So if you have a lower level of potassium, the muscle is less likely to respond to the impulse. Paresthesias, where people feel like they have like abnormal touch sensations, so they might feel like pins and needles in their hands or and feet. Also, decrease digestive tract motility. And because of the decrease in the motility of the digestive tract, you can also have nausea and vomiting, as well as a decrease in the appetite. With severe potassium deficits, the respiratory muscles can also become weak, and this will lead to shallow respirations. Also, renal function can be impaired in the severe cases as well, and this leads to the failure of the kidney to concentrate the urine, and what happens is they have polyuria, so they can't concentrate the urine, so they just have large output of fluid. So I'm not sure if you guys have gotten into EKGs yet, but here are examples of what an EKG might look like in cases of potassium alterations. So this is a normal one. So this shows the cardiac activity through the cycle of a beat, how the electrical impulse is distributed through the heart. So here you have this is completely normal. And the abnormalities that you would see in hypokalemia, right here, you have a long PR interval. So remember this basically tells you the time from the impulse to the response, the impulse traveling from the sinoatrial node to the down through the ventricle. And so if you can see here with hypokalemia, remember the membrane potentials are decreased. So there's a prolonged PR interval. The other thing that you get here are shallow T waves and prominent U waves. All of these changes indicate a prolonged repolarization. Hyperkalemia is elevated serum levels of potassium. Common causes include renal failure, deficits of aldosterone, and also the use of potassium-sparing diuretic drugs. So they prevent potassium from being secreted in adequate amounts. They were created to counteract the hypokalemia normally encountered by people on loop diuretics, but in turn, now we have people becoming hyperkalemic when taking those potassium-sparing diuretics. Also, you can become hyperkalemic when the intracellular potassium leaks into the extracellular space. And this happens usually with people with extensive tissue damage, like traumatic crush injuries or burns. Potassium can also be displaced from the cells in cases of prolonged or severe acidosis. Effects of hyperkalemia include cardiac dysrhythmias. Remember, potassium determines the membrane potential of the cell. So with increased amounts, you would expect the membrane to be easily activated or irritated. So we'll go back and look at the slide with the EKG so you can see what the effects are there. But these dysrhythmias tend to be more lethal and can lead to cardiac arrest. So here is an EKG that's typical in hyperkalemia. This peaked T wave is hallmark in hyperkalemia, as well as this decreased amplitude of the R wave. Muscle weakness is also common, and depending on the severity of the hyperkalemia, it can advance to neuromuscular impairments like paralysis, also respiratory arrest. Calcium is an important extracellular cation. It's ingested in food, especially in milk products, and is stored in bone and excreted from the body in the urine as well as feces. Calcium balance is controlled by the parathyroid hormone and calcitonin, but it's also influenced by vitamin D and phosphate levels. Calcium and phosphate ions in the extracellular fluid have a reciprocal relationship. So, for example, if calcium levels are high, phosphate is low. The product of calcium and phosphate concentrations should be a constant value. So if both calcium and phosphate rise, crystals of calcium phosphate precipitate into the soft tissues. And what this does is it provides and a biologically active form of calcium, so a usable form of calcium to the body. So in addition to calcium providing structural strength for bones and teeth, they also maintain the stability of nerve membranes and control the permeability or excitability for nerve conduction, as well as muscle contractions. Most common causes of hypocalcemia, which is the decreased levels of serum calcium, are hypoparathyroidism, malabsorption syndrome, deficient serum albumin, and increased serum pH. The effects of hypocalcemia are related to the increase in the permeability and excitability of the nerve membranes, and this can lead to spontaneous stimulation of the skeletal muscles, so you can have this muscle twitching, which we refer to as tetany, and hyperactive reflexes. It can also cause paresthesias, which is those pins and needle feeling, and there are two signs that I put on YouTube. One is the Chavostic sign, which is the spasm of the lip and face when you tap in the front of the ear, and then the carpopedal spasm when blood is occluded in the upper extremity, and that's called Trousseau's sign. I put some videos of those up so you can see an exam. It's better for you to see it than for me to try to explain it, and that's related to the increased permeability and excitability of the nerve membranes. The other thing is, calcium is needed for all muscle contractions, but especially cardiac muscle. And so what ends up happening is, without calcium to enter the cell and cause that contraction, you have weak heart contractions that can lead to arrhythmias. And the effects of the decreased calcium on the nervous system can lead to mental confusion and irritability. Hypercalcemia is the excessive serum levels of calcium, and it frequently results from an uncontrolled release of calcium ions from the bones. This can be due to like a malignant neoplasm, or that directly destroy the bone, and some tumors like bronchogenic carcinomas even secrete parathyroid hormone. And this is in excess of what the body actually needs, and that parathyroid hormone causes tells the bone to say, hey, release calcium. And other parts of the body to reabsorb, and we'll talk about that a little later. Also, hyperparathyroidism does the same thing, and again, we'll discuss that later in the presentation. Immobility, so that decreases stress on the bone, and so what ends up happening is the bone's like, well, we don't need it anymore, so it starts to break down, or it's called demineralization. This is one of the main reasons why we tell people who have osteoporosis, or everybody should exercise, but particularly with osteoporosis, they already have this softening of the bone and demineralization that's happening. So we tell them to exercise to combat that demineralization. So remember that immobility can cause demineralization. Also, increased intake of calcium, and that's due to either excessive vitamin D or to excessive dietary calcium. Remember, you need vitamin D in order for your body to even be able to absorb calcium. And lastly, there's a syndrome mentioned in your book, this milk alkali syndrome, and this is just associated with increased milk and acid intake. This is another teaching point. As a nurse, you know, you have people who may want to self-medicate. They have heartburn. Oh, I have heartburn. I have heartburn, and they take over-the-counter Tums, and they think, oh, it's fine, but it can lead to some serious alterations, not only in serum calcium, but also with phosphate levels, and not to mention the constipation. So high serum calcium levels lead to depressed neuromuscular activity, and this can lead to muscle weakness, loss of muscle tone, lethargy, stupor, and sometimes personality changes, as well as apathy, where, you know, people just don't care about anything anymore. Also, high calcium levels interfere with the function of antidiuretic hormone in the kidneys. And so this results in less absorption of water and polyuria. If the hypercalcemia is severe, then blood levels can drop, and then renal function decreases, and there's an accumulation of nitrogenous waste in the blood, which can ultimately lead to cardiac arrest. Arrhythmias can also occur, and this is because the cardiac contractions increase in strength, and remember the role of calcium in cardiac function. Anytime you need calcium to go into the cell to cause a contraction, so it increases the increase in the amount of calcium increases the amount of tension in the cardiovascular system. If excess parathyroid hormone is the cause of the hypercalcemia, then you could have problems with bone density, and people will have spontaneous fractures, and particularly in weight-bearing areas. Now, if the cause is due to increased intake of calcium, then of course you won't have that problem. The other thing is increased circulating serum calcium can also lead to kidney stones in the urinary system. Quick review of magnesium. It is an intracellular ion, and about 50% of the total body magnesium is stored in the bone. Serum levels are linked to both potassium and calcium levels. You guys may have already seen this in the clinical setting. If somebody is severely hypokalemic, they'll be on an electrolyte replacement protocol, which includes magnesium, calcium, and potassium supplementation. For the most part, magnesium is found in green vegetables, and it's is important in many enzyme reactions, as well as in protein and DNA synthesis. And the thing is that magnesium imbalances are very rare. The most time that you'll see these it's as a result of a potassium issue, or in the clinical setting when someone is on some type of magnesium therapy, either for bronchial spasms or in the OB setting for pregnancy-induced hypertension. So those are usually the only times that you see magnesium imbalances. More rare causes of magnesium imbalances are, well, particularly hypomagnesemia, are alcoholism, diuretics, diabetic ketoacidosis, hyperparathyroidism, and hyperaldosteronism. The effects of hypomagnesemia include neuromuscular irritability. Remember, magnesium has a calming effect on the neurological system. It's a relaxing effect, as well as on skeletal muscle, or well, smooth muscle. And this is why we use it with for bronchial dilation in status asthmaticus, as well as in pregnancy for preterm contractions, um, and um, and for high blood pressures. Not for the blood pressure effect, but to prevent the neurological system being irritated by the high blood pressures. So just always remember, magnesium has a calming effect. So um, if you're a deficient of magnesium, you have neuromuscular irritability, tremors, or chorea, those repetitive disorganized movements, similar to that people have in Huntington's disease. Also insomnia, personality changes, and an increase in heart rate with arrhythmias. Now, conversely, hypermagnesemia, one of the main causes is renal failure, um, and that's what you'll see most often in the clinical setting, outside of the ones that we cause by putting them on magnesium therapy for other reasons. And the effects of hypermagnesemia are the opposite, of course. So you would have a decreased neuromuscular function, decreased reflexes, also lethargy, and cardiac arrhythmias that usually deal with prolonging of the repolarization or depolarization. So phosphate ions are located primarily in the bone, but circulate in both the intra and extracellular fluids. It's important in a variety of circumstances, and bone and tooth mineralization are the main ones that come to mind, and but they're also important uh, in metabolic processes. So remember, cellular energy is ATP, so adenosine triphosphate. So you need phosphate to make the energy for the cell. It's also a buffer for the acid-base system, and we'll talk about that more in our next lecture. Phosphate is also an integral part of the cell membrane, and as I stated before, it has a reciprocal relationship with serum calcium. Causes of hypophosphatemia include malabsorption syndromes, diarrhea, and excessive antacid use, and causes of hyperphosphatemia are the most common is renal failure. If you think about it, due to the relationship of phosphate and calcium, the manifestations of hyperphosphatemia are the same as those of hypocalcemia. Chloride is the major extracellular anion. It likes to stick with its buddy sodium because of the attraction between the electrical charges. And so if you have high sodium levels, you'll have high chloride levels. And inversely, low levels of sodium lead to low levels of chloride. Chloride and bicarbonate ions are both negatively charged and can exchange places in as the blood circulate through the body to assist with maintaining acid base balance. And we'll talk about that next week. But generally speaking, as bicarbonate ions are used up in binding with metabolic acid, chloride ions diffuse out of the cell, the blood cell, into the serum to maintain the same number of negative ions in the blood. So it's basically achieving that electroneutrality. The reverse happens, can also occur when the serum chloride levels decrease. So if you have a decrease in the serum chloride levels, then the bicarbonate ions leave the blood cells, and this maintains the electrical neutrality. So low serum chloride leads to high serum bicarbonate or alkalosis. Okay, and this is referred to as a chloride shift. And the only reason why I bring it up during this lecture is that is the most common cause of hypochloremia. And the most common cause of hyperchloremia is excessive sodium chloride. Although the body appears to be a solid object, approximately 60% of an adult's body weight consists of water. An infant is a little higher at 70% water, and females' bodies contain a higher proportion of fatty tissue and have a lower percentage of water than male bodies. The elderly and the obese also have lower proportions of water in their bodies. Individuals with less fluid reserve are more likely to be adversely affected by any fluid or electrolyte imbalances. Okay, so that means who are mostly affected by fluid and electrolyte imbalances. Body fluid volume is regulated directly in the extracellular compartment and indirectly in the intracellular compartment by the kidneys. To maintain a constant level of body fluid, the amount of water entering the body should always equal the amount of water leaving the body. So fluid is added to the body by ingesting solid foods and fluids, and as the product of cell metabolism. And then we lose fluid through urine and feces, as well as insensible or unapparent losses through perspiration and exhaled air. Fluid constantly circulates throughout the body and moves freely depending on the permeability of membranes between the compartments. And this happens through the process of filtration or osmosis. I wouldn't get too caught up in these details. I mean, it's good to know in order to achieve a deeper understanding of how certain medications work. However, focus on the mechanisms of membrane transport outlined in the diagram here and listed on page 204 of your text. Fluid balance is also promoted by the thirst mechanism in the hypothalamus. Be sure you understand this negative feedback system and the roles of the renin-angiotensin-aldosterone system and how it affects blood volume. I wanted to briefly talk about edema because this seems to be one of the things I'm asked most about by students in clinical environments. The osmolarity or concentration of solute in fluid affects the fluid shifts between compartments, and this includes cells. Edema refers to an excessive amount of fluid in the interstitial compartment, which causes a swelling or enlargement of the tissues. So this fluid has shifted from the intravascular space or the extracellular space into the interstitium, okay? And This can be caused by numerous, well, four things, okay? And we will talk about an exact example later on. The first cause can be an increase in the capillary hydrostatic pressure. So we could say that this is kind of like having a higher blood pressure, which prevents the return of fluid from the interstitial compartment to the venous space. Basically, there's tension in the system, not allowing the fluid to return to the capillary. Or it could be that this increased pressure in the vasculature forces excessive amounts of fluid out of the capillaries into the tissue. We see this in like pulmonary edema, where there's excessive pressure in the pulmonary vessels, and it's often due to increased fluid volume, and this forces the fluid into the alveoli and interferes with the respiratory function. Other specific causes of edema relating to this increased hydrostatic pressure are we said increased blood volume, but kidney failure. So, the kidneys are not filtrating and are not putting out the amount of fluid, so it leads to hypervolemia. Pregnancy, this is the what happens in pregnancy as well. They're dealing with all this, like a 30% increase in blood volume. So this is why pregnant women tend to third space or have dependent edema. Congestive heart failure, of course, is another very common cause of this increased hydrostatic pressure. And I'm sure you've seen this a lot in clinical. And then administration of excessive fluids as well. So that's an iatrogenic cause of increased hydrostatic pressure. Another cause of edema could be related to the loss of plasma proteins, and this is especially albumin, and this leads to a decrease in the plasma osmotic pressure. Think of as osmotic pressure like the force that holds water in a space. So albumin helps to hold water in the vasculature. If the albumin is low, then water leaks out of the vasculature into the interstitium. And because water has an affinity for albumin, it also means that less fluid will return to the intravascular space. We see this a lot in kidney disease because a lot of the protein is lost in the urine due to the damage of the glomerulus, and this allows macromolecules like protein to leak out. We also see this when the synthesis of proteins may be impaired, like in liver disease. And we're going to talk about a liver disease that does that too. The other thing to note is that frequently excessive sodium levels in the extracellular fluid accompany both of these types of both of these mechanisms that lead to edema. So think about it like this. When sodium ions are retained, they promote the accumulation of fluid in the interstitial compartment. And this is because they increase the osmotic pressure there in the interstitial space. So when sodium leaks to this space, you know how water loves sodium, so it's less likely that it's going to return back to the fluid in the blood, in the vasculature, if that makes sense, because now the osmotic pressure is high in this interstitial fluid. High sodium levels are common in patients with heart failure, high blood pressure, kidney disease, and increased aldosterone secretion. The third cause of, well, I'm going to skip here. I know the diagram has this as E, but I'm going to skip here to the lymphatic obstruction. So, lymphatic obstruction can also cause localized edema, and and this is because, hold on, my dog, hold on. Okay, so sorry about that. Obstruction of the lymphatics is where we were. So this causes. Good morning, Chloe. Okay, let's try this again. So edema can result from the obstruction of lymphatic circulation because the excessive fluid and proteins are not returned to general circulation like they usually do because of the blockage that's preventing it. This happens frequently when you have a tumor or an infection that damages the lymph node, or if parts of the lymphatic tract are removed, like in surgeries for cancer. And then the last cause that I'll talk about is the increase in capillary permeability. Okay, you guys should all be familiar with this from our quizzes on infection and inflammation. So this kind of this usually causes localized edema, and it's the result of an inflammatory response. So remember, in that inflammatory response, those chemical mediators, namely histamine and prostaglandin, are released, and this increases the permeability of the membrane of the cell, and this promotes fluid movement out of the cell into the interstitial area. So when this happens, usually protein also leaks into the interstitial compartment, and with that protein, remember protein increases osmotic pressure. So now this kind of potentiates the situation and increases the amount of fluid in the interstitium. One thing I also want to make clear about edema is that if someone has edema or is third spacing, that means that that fluid is not available for circulation. And so even though we consider this a disease of fluid volume excess, in the vasculature, they have less fluid available to them and can be ultimately dehydrated. So, cirrhosis is a disorder in which the liver demonstrates extensive diffuse fibrosis and loss of lobular organization. So basically, it's the hepatocytes, the functional cell of the liver is damaged, and there's an interference with local blood flow. The thing is that hepatocytes tend to regenerate, and that's great. But the problem is the fibrosis, and even once the causative agent is identified and removed, you're still left with a scarred, hardened liver. And this scarring or fibrosis interferes with the blood supply to the tissue. And bile may back up, and it also leads to ongoing inflammation and damage. Initially, the liver is enlarged, but then it becomes smaller because it shrinks as the fibrosis proceeds. So during the period of ongoing inflammation, it's swollen. Then it shrinks as a result of fibrosis. And what's unfortunate about cirrhosis is that in the beginning, a lot of the degenerative changes are asymptomatic, and they don't start having symptoms until it's the disease is well advanced. So the reason why we're talking about cirrhosis is because one of the these the clinical manifestations of cirrhosis is a disorder called ascites, and it is a representative of several different pathways of third spacing. So this diagram pretty much shows you the hot, you know, the hot spots of the development of ascites. So as a result of all of that scarring, you have a high pressure in the portal veins and the lymphatics as well. Okay, so this in conjunction with other factors affects a fluid shift in the hepatic portal system, leading to ascites, or the third spacing of fluid from the vasculature into the peritoneum. So this portal vein hypertension increases the hydrostatic pressure in the veins and lymphatics. Okay, and and as a result of this increased hydrostatic pressure, the fluid shifts out of the portal circulation into the peritoneal cavity. Okay. But what you also have is an increase uh, in, let's go, in the serum aldosterone levels. Okay. And so what happens is that this leads to increased sodium and water retention. Okay, so you hold on to this, and then the fluid shifts out of the portal circulation into the peritoneal cavity. And then thirdly, you have the decrease in synthesis of albumin by the liver. Okay, so remember what I said about albumin when we were talking about edema. Albumin holds in water. So with the decrease in the amount of albumin, that water just shifts out of the cell because there's a decreased osmotic pressure in the plasma. So the water shifts out of the cell. All of these things, all four mechanisms of third spacing that I discussed are represented right here in ascites. So as this fluid accumulates in the peritoneum, it pushes up on the diaphragm, and this impairs respirations. It also, you have all this protein-filled fluid in the abdomen, in the peritoneum, that's just floating around there. So you have an increased risk of peritonitis, and in the abdomen due to this fluid. It's basically like a belly full of like a big belly of a petri dish. And then you also have impaired digestion and absorption as a result. So although, the disorder that we're looking at is cirrhosis, really what you want to focus on is ascites, and what was on that last slide as far as the development of ascites. But generally speaking, cirrhosis, signs and symptoms, fatigue, anorexia, indigestion, weight loss, metabolic dysfunction in the liver. Remember, your liver is the main area of metabolism. If your liver isn't working right, you're just not living right. So you would have not only, problems with metabolizing medications and things like that, but you have decreased gluconeogenesis, a decrease in bile for digestion. So that's what leads to that indigestion. And you have issues with absorption. We talked about the portal hypertension, and that's due to all of that scarring on in the liver that just leads to the backup of lymphatics as well as the vessels, the blood vessels, and this leads to not only the fluid shift that we talked about, but edema in the intestinal wall. And so that contributes to the problems with digestion and absorption as well. The This increased portal tension, or portal hypertension is what they refer to it as, also builds up pressure in the esophagus, and you end up getting basically hemorrhoids in the esophagus. We refer to these as esophageal varices. It's just basically a backup of, well, just hemorrhoids. But they're blood filled, and the most dangerous thing about these esophageal varices is that they're full of blood. So rupturing of these varices in the esophagus can be a life-threatening issue, and they can bleed out from rupture. And think about, what else does the liver do? It deals with clotting time. So there's an increased risk of those varices rupturing, and as well as an increased risk of bleeding everywhere. Sometimes they'll have what we'll call purpura, or basically you'll see on their skin ruptured little blood vessels. Okay. They can have splenomegalia, which also from the portal hypertension, the buildup of that blood, just causing the spleen to enlarge. So in addition to their increased risk for bleeding, they also are more prone to anemia because of the decreased absorption and storage of iron, vitamin B, and just overall malabsorption. They also have leukopenia, thrombocytopenia, and this is most likely due to the bone marrow depression by the increased ammonia and other toxins that aren't being filtered out from the blood because of the liver. They can have hepatic encephalopathy, uh, tremors, confusion, worst case scenario, go into a coma. And again, this is related to that metabolic dysfunction, with the inability to remove the ammonia, and other toxic substances. It can have gynectomastia, or enlarged breast tissue. Women can have irregular menses, and this is due to the inactivation of sex hormones. And then, of course, they can be jaundice. Anytime you have a liver dysfunction, uh, you have impaired extraction and conjugation of bilirubin, and this it stems from uh, the decrease in the production of bile. Okay, because remember, with cirrhosis, there's an obstruction of that bile flow as well. Another thing that these people can have is pruritus, and that's from the buildup of the bile salts in the tissue. So it's just like a generalized itching. They just itch everywhere, and you might see excoriations from them scratching, but you won't see any kind of lesions or anything like typical of a rash. Um, Diagnosis of cirrhosis. A good history, of course, the body weight. That these people tend to be very, very thin, but have a a large round abdomen. Think about it. They have malabsorption. So they are losing weight, but they might have this increased abdominal girth due to cirrhosis. Um, Laboratory tests, specifically for ascites, it would be a fluid analysis, and that's namely because you want to make sure that it is indeed uh, fluid, and as far as uh, not blood, like it's not, they're not having any internal bleeding that's leaking into the perineum, but it's indeed third spacing and fluid from the vasculature. You also want to make sure, you want to rule out any type of infection. Remember that having that protein petri dish fluid in your abdomen is just a haven for bacterial infections. You want to check liver and renal functions, and as well as cardiac function. And the main reason that you check cardiac function is, you think about it like this. So you have this increased portal hypertension, okay? So, that increases peripheral vascular resistance. So that increases workload on the heart, and eventually, these people can have heart failure. Treatment of cirrhosis is mostly supportive or symptomatic. So you want to um, promote rest, so they avoid being fatigued, because remember, they are not metabolizing anything, and so they're not getting the nutrition they need, so their cells aren't going to have the energy they need to carry out their daily functions, activities of daily living. You want to make sure that they know that they need to reduce their exposure to infection. They need to get all their immunizations and protect themselves against uh, infection. They need dietary restrictions in protein, as well as in sodium intake. They may also need to take on a low fat diet. Remember, the liver makes bile. The liver's not working. Okay. With the remember the protein and sodium intake restrictions stem it directly from the fact that it increases the likelihood of further third spacing. High carbohydrate intake and vitamin supplementation is necessary. Their serum electrolytes need to be watched very closely and balanced. They may require the use of diuretics to reduce the body fluids. Sometimes, in the case of ascites, what they do is a pericentesis, not only to examine the fluid to make sure that it is, there's no infection going on there, but also to relief. Remember that the accumulation of fluid pushes up on that diaphragm. It increases tension in the system. It promotes further migration of fluid out of the vascular space into the interstitium. So removing that fluid definitely can help. Antibiotics, like neomycin, are also useful to reduce any kind of intestinal flora, and control serum ammonia levels as well. I kind of mentioned this before, but let me reiterate that whenever you have ruptured esophageal varices, it is an emergency um, situation. People with cirrhosis need to know if they start vomiting blood, or if they notice blood in their stool or black tarry stools. They need to seek immediate medical attention. Um, One treatment that it can prove useful in reducing the portal hypertension is a portocaval shunt. And then ultimately, they need, especially, I mean, depending on the extent of the cirrhosis, a liver transplant is another option, depending on, where they're at in the disease process. Now we'll talk about dehydration, which is basically a fluid volume deficit. Dehydration is characterized by negative fluid balance. The most common causes are diarrhea and vomiting. Okay. But there are other things that can lead to dehydration as well. As you see here, fluid shift between compartments like ascites. So third spacing. This is why I mentioned that before. So someone who looks like they have plenty of fluid because they have edema, yeah, they do have plenty of fluid. It's just not where we want it to be. So they are essentially dehydrated. This chart is directly from your book, and it just talks about the different types of dehydration. The most common is this isonatremic, and that's where there's no shift in or out. Okay, and it's just that they need more fluid. So this is the person that you're rehydrating with normal saline, okay, or lactated ringers. Okay. Then you have a hyponatremic, okay, intravascular goes to extravascular. So remember, so there is a decreased amount of sodium inside the cell. It's more on the outside. Water flows where salt goes. So the perfect example of this is third spacing. Okay. So you have the increased osmolarity on the outside of the cell, and the fluid just follows the salt into the interstitial space. Okay. Then you have hypernatremic. So this is when it's more sodium inside the cell, and this is usually like as a result of like getting rid of large volumes of urine, but not sodium. And in this one tends to be less unbalanced, I guess is the best way to say it, because if you think about it like this, so yes, the fluid shifts from the extravascular space into the intravascular space. So the person is less likely to exhibit signs and symptoms of dehydration, if that makes sense. We could talk about it more in class if it doesn't. This is just a comparison of the clinical manifestations of fluid volume excess versus deficit. Of course, you want to look at the eyes. Sometimes they'll have sunken eyes. They have that decreased skin turgor and dry mucous membranes. Think back to your health assessment class. Thirst, sometimes weight loss, because we're made up of mostly water. They can have a rapid, thready pulse and low blood pressure. Or they're more sensitive to changes in position. Their blood pressure is more sensitive to changes in position because they have less fluid in that space. So when they stand up, they don't have as much blood to pump to their brain. So they get dizzy, if that makes sense. Fatigue, weakness, dizziness, possible stupor, depending on the severity of dehydration. Increased body temperature. Think about it like this. Whenever, let's see, what's the best way I can explain this? I guess the best way that I can explain is that with dehydration, you increase your body's heat storage. You store more heat. Okay. Like think about it, you sweat to dissipate heat, right? And cool yourself down. Well, if you can't sweat, you can't get rid of heat, correct? So you have increased body temperature related to the increased storage or holding on to that heat. As far as your laboratory values, increased hematocrit, and it could be increased electrolytes depending on the cause, but usually when there is an increase, it's because it's hemi concentration, meaning you have the same number of cells but a decreased volume, right? So it's your blood is concentrated, okay? And on urine dip, you have high specific gravity and a low volume. So decreased output of urine because you don't have anything to make urine, and a high specific gravity because just like with the blood is concentrated, the urine is concentrated too. So the solutes that are dissolved in the urine appear to be increased because there's a decreased amount of fluid. So in diagnosing and even monitoring hydration status, fluid intake and outtake is crucial. Also asking and examining the characteristics of their urine, their stools might be hard, they might be constipated. Emesis as well, like any recent, have they, as far as urine, you want to know if it's concentrated, but also have they had large volumes? Have they been peeing a lot? Okay. And with emesis, to say, have they had any recent bouts with nausea or vomiting? Or have they been sweating a lot? You want to know what their intake is like as well. Or do they have a normal diet, or have they had something really salty lately, or do they not? It's really about their salt intake, right? Laboratory values. So you look at blood concentration of electrolytes, also bicarbonate. Remember, bicarbonate and sodium chloride are the main sources of sodium in the body. You look at BUN and creatinine because these are measures of how that kidney is functioning, and you look at the spec gravity because we talked about that. Treatment of dehydration, it depends on how bad it is. Okay, you want to rehydrate them, and that could be done orally or intravenously. Um, you know, it really depends on what kind of signs and symptoms they're manifesting and what population you're dealing with. When you're talking about a newborn or a child in general, they carry more water, and depending on how dehydrated they are, they may need intravenous replacement. Another example is with pregnant women. Pregnant women, when they're dehydrated, it causes contractions. So you don't want to orally hydrate these people. You want to, especially if they're contracting a lot, you want to give them IV hydration. And if there's an electrolyte imbalance going on, then you want to fix that, because if you don't fix that, then you're just going to have more of the same. Okay, and that's in the cases of the hyper and hyponatremic electrolyte imbalances. Another thing that's important to note is if you rapidly rehydrate somebody who is hypernatremic, what you can do is you can cause cellular swelling to the point of rupture of the cell. So you have to be very cautious in rehydrating them. Whereas with a young, healthy, pregnant woman, you can just bolus her bags and bags of fluids. You can't do that with someone who may be hypernatremic. Now we'll talk about hypoparathyroidism. And this is an example of altered calcium balance. It's usually caused by either a congenital lack of one of the four parathyroid glands, and those are located just where they're shown in this picture, parathyroid, around the thyroid. And or it could be following the surgery where for like radiation on the thyroid or in this region of the neck um, that would cause the underactive parathyroid. Sometimes, just like with any other gland or organ, an autoimmune disease can also destroy the parathyroid glands. So, like I said, it leads to alterations in calcium balance. This is a review of the how calcium balance is maintained in our blood. So basically, we sense the that the hypothalamus senses that calcium is low in the blood. It tells the pituitary gland that it needs to secrete parathyroid stimulating hormone. Parathyroid stimulating hormone then acts on the parathyroid. Okay. And the parathyroid secretes parathyroid hormone. And parathyroid hormone works on the bone to release calcium into the bloodstream. So basically, it demineralizes the bone and to allow for circulation of free calcium. Parathyroid hormone tells the kidney to increase reabsorption of calcium in the kidney, and this circulates it back into the blood. And then it also tells the intestine to increase absorption of calcium there. This leads to increased levels of blood calcium, which inhibits the further secretion of parathyroid hormone. So this is what we talk about when we say a negative feedback system. Either the absence of something leads to the stimulation of to produce it. So in the case of hypoparathyroidism, this I'm sorry. The parathyroid glands are under producing parathyroid hormones. So so you're not getting this normal feedback mechanism. Okay. And in that case, what happens is that you have low levels of serum calcium. So remember what calcium does. It has effects on muscle function and nerves, but it affects them in different ways. So low serum calcium levels lead to weak cardiac muscle contractions, but it increases the excitability of nerves, so leading to the spontaneous contraction of skeletal muscles. But the heart doesn't work independently. The nervous system plays a part. So you have these weak cardiac muscle contractions and these excitable nerves, and this can lead to arrhythmias and hypotension. In the skeletal muscles, because of the excitability of the nerves, this leads to like spontaneous muscle twitching and spasms, and we call it tetany. They can also, depending on the severity of the hypocalcemia, they can have chorea, so those repetitive movements. And I talked about this on the slide for hypocalcemia. So those signs, it was Trousseau's sign. They'll display all of those manifestations of hypocalcemia. Okay. Another thing that I wanted to mention, so even though calcium has an effect on all muscle, the effects of hypocalcemia are more profound on the cardiac muscle. And that's because with skeletal muscles, they usually have enough like calcium stored within the skeletal muscle. So it doesn't weaken the muscle contractions. And the things that you see in the skeletal muscle are more related to the stimulation of the nerves, the excitability of the nerves. Now, in cardiac muscle, the reason why you see the weakened contractions there is because cardiac muscle doesn't store calcium. So it relies on the serum calcium concentrations. Diagnosis, medical and surgical history. So as always, sometimes, like I said, this could be iatrogenic. We were trying to treat the thyroid and we damaged the parathyroids, or we saw in clinical there, alterations to the pituitary gland too. Excision of a pituitary tumor, which would lead and decrease thyroid parathyroid stimulating hormone from the pituitary. So any kind of surgery like that, it's important to know of. Doing a physical exam, looking for some of those defining clinical manifestations, and also laboratory tests. So parathyroid hormone serum tests, blood for calcium, phosphorus, and magnesium. Remember, there's a correlation between those three. And also looking for urine calcium, because they might have calcium, but maybe the kidney is excreting it at high rates. So checking the urine for calcium. Treatment includes calcium supplementation, as well as vitamin D. Remember, you need vitamin D in order to use the calcium. And then also recombinant parathyroid hormone, meaning just basically replacement therapy.